Well, good morning. Welcome. Welcome to Sunday morning coffee with Dr. Childress. Today I'm going to be talking about treatment issues surrounding court involved family conflict. Uh, to begin with, on treatment, my cat's walking around. To begin with, on treatment, the issue is diagnosis. Diagnosis always guides treatment. The treatment for cancer is different than the treatment for diabetes. I find it phenomenal. I have to keep saying that, but I do because the forensic psychologists can't seem to understand that concept. So I have to kind of make it very simplistic for them. The treatment for cancer is different than the treatment for diabetes. So the very first thing that the psychologist should do is determine the diagnosis. Are they treating cancer or diabetes? And that is a significant flaw that's over here in the family courts. People start doing things and they have no idea what the diagnosis is. What is the pathology they're working with? Now, I want you to listen to these two sentences because these two sentences mean exactly the same thing. We must first diagnose what the pathology is before we know how to treat it. We must first identify what the problem is before we know how to fix it. Diagnosis means identify, pathology means problem, treatment means to fix it. And again, I find it amazing that I have to explain that to psychologists, that if they haven't diagnosed what the problem is, what the pathology is, then they haven't identified what the problem is. But they're just jumping into fixing things without having first identified the problem. That's insane. Is it cancer or is it diabetes? If we treat diabetes with insulin, the patient dies from the misdiagnosed cancer. So it's really, really important that our treatment is based on an accurate diagnosis. Now, if we diagnose a pathology and then treat it, we would expect that the treatment is going to fix the pathology. That's what treatments do. So if you go into a medical doctor and you have high blood pressure, that's the diagnosis. They put you on high blood pressure medication that should bring down your blood pressure. If it doesn't, if the treatment doesn't work, then that's an indication of one of two things. One, you've misdiagnosed the pathology, or two, you are incompetent in applying the treatment. Because if it's the right diagnosis and you're competent in delivering the treatment for that diagnosis, it should fix the pathology. That's what treatment does. So we have a family court conflict that goes on for years of unsuccessful treatments, unsuccessful approaches to fixing things. That means one of two things. Either your diagnosis is wrong, which it is, or two, you're incompetent in applying the treatment, which you are. So there's just fundamental problems in forensic psychology and in the approach of forensic psychology. What happened? The systems are broken. And that's what you as parents, you as the court system is running into, is that the mental health system is broken. And here's how it's broken. This pathology is very dangerous. The pathology itself is dangerous, narcissistic, borderline, dark personalities. They are very vengeful, very retaliatory. They are delusional, so they're not anchored in actual truth or reality. And that's a dangerous human who is vengeful and not anchored in reality. In addition, they are dangerous to the clinical psychologist because we are trying to interrupt and interfere with what they want to accomplish, what they need to accomplish, which is to gain sole possession of the child. So they are particularly focused on getting us gone, the treatment people gone. So the pathology is dangerous. The cross-examination, the opposing counsel, is very dangerous. If we try to interfere or do something, they're going to go after our license on the stand. And so that puts us at risk. And we're not used to testifying as clinical psychologists. We have to be very precise in our words. Otherwise, the pathological parent will use our testimony and go to the licensing board and just make our lives uncomfortable and miserable. So that's dangerous. So because of the danger of your families and the risks associated with them, psychology, professional psychology, did a risk management response back in the 1980s, where they gave you your own special psychologists. They're called forensic psychologists, and you're the only pathology in all of mental health who have your own special psychologist just for you, who, interestingly, don't diagnose and don't treat the pathology. They do something different. These forensic psychology have as their goal something about custody. They become mini judges deciding on who the child should live with, the custody issues. That's not the role of doctors, to decide on custody issues. And that is also consistent with what the pathology wants. The pathology wants to drive this into the court system to put the parents on trial, the other parent, the other spouse on trial, having to prove that they deserve to have a parent, deserve to have a child, to make it as hard as possible to see the child. It takes months to get court orders. Meanwhile, all the Machiavellian manipulation that they're doing to get sole possession of the child is working. So they have sole possession while you have to argue with the court to get equal shared time and prove to a forensic psychologist that you deserve to have a child and deserve to be a parent. And so I got a cat down here going after my feet for a second here. So let me just address this. Get away. Get away. And so the forensic psychologists don't diagnose, they don't treat, they play along with the intent of the pathology to make this about custody rather than about treatment. The pathology does not want to make this about treatment because it doesn't want anything fixed. And a diagnosis will identify what the problem is, what the pathology is, that it's them. So the pathology, the pathological parent, does not want this into clinical psychology and treatment. And the forensic psychologists are going along with that. So it is the fundamental premise of forensic psychology is wrong. This isn't a custody issue. This is a treatment issue. We need to fix the attachment pathology in the child. Forensic psychology is a failed model of service delivery to a vulnerable population. It is failed. In 1980s, they decided to give you families and the family courts your own special psychologists. That was a wrong decision that has led to 40 years of child abuse and family suffering and family conflict and has solved nothing. Clinical psychology needs to return to court-involved professional practice. Another additional problem, though, with clinical psychology coming back, in addition to it being dangerous from the pathology and dangerous from the legal system and opposing counsel, is that the forensic psychologists are now dangerous to clinical psychologists. If we come back and do something that's not forensic, that they don't like somehow on the licensing boards, they want to get us gone, they will sanction us. And so, and as a clinical psychologist in forensic world, going up against a licensing board of forensic psychologists, there's no appeal to that. So they will drive us away. It's too dangerous. There's three aspects of the danger to a clinical psychologist. I'm an old clinical psychologist. Look at my vita. This is not my pathology. I came out of foster care, child abuse, entered private practice, accepted one of these clients, court-involved clients, because I knew what I'm doing. I know what the pathology is, and I'm wondering why you guys can't solve it. I found out with that one client, I began to unpack things and unravel what was going on over here. And it's a broken system, the mental health system, because there's no diagnosis. The guide treatment, there's no treatment. That's been the case so part of my role here is I am remaining a clinical psychologist in court-involved practice. That's very dangerous to me. Every testimony is very dangerous to me. I have the forensic psychologists in Oregon have already retaliated against me. It cost me $50,000 to fight a $7,500 sanction because it has to be done. Clinical psychologists have to come back. And so I'm the first, and my role is to make it safe for the other clinical psychologists to return, which is a lot of what my diagnostic checklist for pathogenic parenting and the parenting practices rating scale and those two and the whole ABPA, the application of knowledge, all of that is designed to make it safe for the clinical psychologists to follow. They can start citing Dr. Childress, and then that, as long as they do the diagnostic checklist and the parenting practices rating scale and make a decision based on the information from that, then they can rely on foundations and all of Dr. Childress to support them in that process. So that makes it safe for the clinical psychologist to return. Everybody's going to argue about the diagnosis. That's a fact. The diagnosis over here, by the way, is child psychological abuse, DSM-5 V995.51, and spouse or partner abuse psychological, DSM-5 V995.82. And it's important to recognize that second spousal abuse diagnosis, because that's the core of the pathology many times that's driving this. It is a spousal abuse pathology using the child as the weapon. And in weaponizing the child into the spousal abuse, they have created such pathology in the child it becomes child psychological abuse. But we have two abuse pathologies potentially here in every case of court-involved family conflict. The reason it's every case is because 80 to 90% of parents at divorce solve the custody without the court's involvement. They just solve it on their own because they have normal range empathy for the child. A group of parents, their spousal stuff gets a little too intense and they're not able to cooperate at the time of the divorce on coming up with what the custody schedule is. So they need to go to the court for that initial determination. Is it shared equal 50-50, or does one parent get school week primacy and the other one get every other weekend? Because that's pretty much the decision. It's not complicated. There's only two patterns, basically shared 50-50. You can do it every other weekend, or you can combine the weeks. Each one has good points and bad points. Or you can do school week primacy to one parent and every other weekend, a day during the week to the other parent. So we don't need a lot. The courts can make that decision. There's not a lot of complication to it. If there's distance between the two of them, geographic distance, then one parent gets school year primacy, the other one gets vacation time and maybe some consideration on that. And again, there's good and bads about all of these things. The best situation is to have a happy, normal range, intact family. That's the best thing. Don't get divorced, fix things in the family, and don't get, but once you divorce, there's bad options all the way across, and then we make our choice. Shared 50-50 would just generally be the default option in my mind. And then if there's geographic or other reasons to make a parent the school year parent, or school week parent, and the other parent every other weekend, the courts can make that decision. So it's not complicated. The issue becomes about 10% of parents cannot resolve that. They get the court decision, but in another year or so, they're back into the courts, even less sometimes, arguing about child custody, typically because the child has attachment pathology towards one of the parents. The child is refusing time, or the child is expressing fears, or whatever. So the child has attachment pathology that reactivates the court's decision somehow about custody. That's a pathology decision at that point. And it should be routine that when those decisions come back to the court that it's already made, it should get bumped out for a diagnostic risk assessment, because normal range people are able to cooperate with court authority and court orders. If they're coming back to modify custody for some reason, especially around child pathology, that strongly suggests we have at least one parent who is not able to follow court orders or kind of contain themselves within the authority of the court. And so they're trying to manipulate the situation with child pathology. Other possibility, though, is that the targeted parent is actually abusive of the child. Okay, so if there's significant abuse going on that requires it to come back to the court to say we need a change in your decision because the targeted parent is somehow abusing the child, let's conduct a proper assessment for that. Let's diagnose what the abuse is, and let's put it on a treatment plan, fix it, and restore the child's attachment bond to that parent. Okay, that's what the parenting practices rating scale is for. Is one of the differential diagnoses is child abuse by the targeted parent. So let's identify level 1, 2, 3, or 4. Let's identify whether it's actual child abuse, levels 1 or 2, or a false belief in that there's being maltreatment, levels 3 and 4. And if this is a normal range, if it's level 1 or 2, that becomes our treatment focus. Child abuse by the targeted parent somehow. If it's level 3 or 4, then it's normal range parenting, so that's not creating the attachment pathology. Okay, parents have the right to parent according to their cultural values, their personal values, and their religious values. And so if there's no child abuse, the psychology people may think their parents a little too strict or a little too lax or have their own cultural values that they want to apply, but that's not our role as psychologists. If there's no child abuse, parents have a right to parent according to their values. Now, we can work on that in therapy or something, but it's not a custody issue unless there's child abuse. So we look at the targeted parent, say, is there child abuse? If there is, that becomes the focus of our treatment. If there's not, then we shift over to the alternative diagnosis that it's child psychological abuse by the allied parent. And that would be a triangle, a 3-person triangle, cross-generational coalition of the child with the parent against the targeted parent. And the allied parent is creating a shared persecutory delusion in the child for secondary gain of manipulating the court's decision surrounding child custody. That's a false disorder. The allied parent is producing a false disorder in the child, in another person, in the child. That's a factitious disorder imposed on another. DSM-5 300.19, and it would be child psychological abuse as well. So either way on this, when this family comes back into the courts to argue about custody when the court has already made a determination about that. The rule out on either side is possible child abuse. It's not the court's role to diagnose child abuse. That's not their role. That's the mental health person. That's the doctor, the psychologist. It's not their court's role to diagnose a delusional disorder or a factitious. No, that's the psychologist again. But the forensic psychologists do not diagnose pathology. And there's one number of reasons that they offer for that are thought disordered, really problematic. Essentially, they're colluding with the pathology. And I can cite their own codes, and I would recommend that we have a debate in professional psychology about the relative roles of forensic and clinical psychology in the family courts. I'll represent clinical psychology. Go find a forensic psychology to represent what they do. I'd recommend Dr. Saul or Simon, who wrote the book here on child custody evaluations, Simon and Saul. Get one of them to argue about the role of forensic psychology and to present that. And I'll take the role of clinical psychology. They have a chapter 2 here, forensic approach versus clinical approach. And I've got little red things. Oh my goodness, I've read it. So I've got their quotes on this, and they bash clinical psychology unfairly. They just make up stuff that's not true. All these straw man arguments going back and forth to justify their existence. So let's debate it. You got a clinical psychologist over here. You've said some bad things about clinical psychology in your book. So I'll represent clinical and I'll defend us. Because my argument is that forensic psychology is a failed model of service delivery to a vulnerable population. We don't need it for autism. We don't need it for ADHD. We don't need it for trauma or eating disorders or for anything else. We do not need special psychologists, nor do we need people to decide who deserves to be a parent. We need treatment professionals who solve the pathology, who solve the problem. So that's the first issue, is diagnosis guides treatment. And we should not be going anywhere on what we do about anything until we have that diagnosis. And everybody, the court starts to do things, GALs start to do things, the therapists start to do things. Everybody's doing things without a diagnosis. And that's a problem when the diagnosis is child abuse. And it's going to be child abuse one way or the other. So we need to get this out to a proper risk assessment to assess whether the targeted parent is abusive or whether the allied parent is psychologically abusive, a shared persecutory delusion, factitious disorder imposed on another, dark narcissistic borderline personality pathology being expressed in the family, Machiavellian manipulation of the court's authority and court orders for child custody by creating pathology in the child. That's the alternative diagnosis. So the implications, part of the implications for you parents about this whole diagnostic and clinical forensic issue is that clinical psychology left 40 years ago, leaving you with forensic psychology. That was the risk management response taken by professional psychology to the dangers associated with this particular form of pathology. So for the past 40 years, there's been no clinical psychologists over here, and there's been no diagnosis and no treatment. And if anybody thinks there's a treatment out there for this pathology, please let me know. There's no treatment for it. What they say, these forensic people, they say they do reunification therapy. There's no such thing. That's just their umbrella word that allows them to do whatever they want to do, and they call it reunification therapy, and it always fails 100% of the time. The reason is they've misdiagnosed the pathology. Oftentimes they've given no diagnosis for the pathology, and they're not competent in attachment pathology or attachment system or family systems therapy, and they're not competent in delusional thought disorders or in factitious disorder or dark narcissistic, borderline personality pathology. They're not competent. So there's a variety of problems with the psychologists you have. So I set all this up to alert you that there is no treatment in the family courts. There's treatment out. We have treatments out in clinical psychology for everything: autism, ADHD, oppositional defiant. We got all sorts of treatments of trauma pathology. But none of them are in the family courts because no clinical psychologists are in the family courts. You get, strange diagnoses, parental alienation. There's no such thing. Contact problems, vague. Just no diagnosis. Resist, refuse dynamic. That's just, again, vague. No research, nothing on it. None of those are diagnoses. And none of those are established knowledge even close to it to meet requirement 2.04 of the APA Ethics Code. So you have no diagnosis and you have no treatment. They just make stuff up and it always fails because they're misdiagnosed or haven't diagnosed the child abuse. So, on the return of clinical psychology, diagnosis guides treatment. We have a differential diagnosis of child abuse one way or the other. If the diagnosis comes back child psychological abuse towards the allied parent, shared persecutory delusion, factitious disorder, what's the treatment for child abuse? There are 4 DSM-5 diagnoses of child abuse: physical, sexual, neglect, psychological. All of them are equally damaging to the child. They differ only in the type of damage done, not to the extent of damage done. Psychological child abuse is devastating. It destroys the child from the inside out. Okay, physical violence is coming from this way. The child hunkers down. Sexual violence is a difficult one on the intimacy channels. Psychological abuse gets into the child's very self and destroys who that child is devastating. In all cases of child abuse, the duty to protect and standard of practice is to protectively separate the child from the abusive parent. We then restore the child's healthy and normal range development. And once we have that recovered and stabilized, we then restore the child's attachment bond or restore the child's contact with the abusive parent with enough safeguards in place that the child is not abused again. The abuse does not resume when contact is restored. We do that with a physically abusive parent. Just use that as an example. Okay, we have a physically abusive parent. We protectively separate the child. We recover the child's healthy development. Then we reintroduce the abusive parent. Hopefully they've had some treatment on anger management things. We put them on supervision for a while. We gradually relax the supervision and we monitor for child symptoms. So that should be happening with these cases. It's not because the mental health people are failing to make the diagnosis of child abuse. So the child abuse is continuing and they're failing in their duty to protect for a variety of reasons: ethical violations of 2.04, 2.01, 9.01, just basic incompetence and failure to conduct a proper risk assessment for possible child abuse, a risk assessment for the possible shared delusional disorder, factitious disorder, all those sorts of things. So we need the child abuse diagnosis to guide the treatment. We need an accurate diagnosis. If there's 2 ways you can get a diagnosis. One is directly. It's a pattern match of symptoms to diagnostic criteria. So it's not an opinion. If you collect your symptoms and if those symptoms are a pattern match to a diagnostic criteria, if you've got hallucinations, delusions, and unusual thought content or conceptual disorganization, you have schizophrenia. And that's your diagnosis if you have a pattern match to the symptoms to the criteria. Whether you like it or not, that's your diagnosis. And so if you have a delusion, a shared persecutory delusion, factitious disorder, child psychological abuse, that's your diagnosis. And that needs to then guide treatment. So that's one way, is to directly look at the symptoms and do a pattern match to the criteria. Now, sometimes though, it's hard to determine whether this symptom meets this criteria or stuff, or it might be a little vague for some reason. Classic example is schizophrenia with depression versus bipolar disorder with psychotic features. Do I have a psychosis with mood problems, or do I have a mood disorder with psychotic features? One I treat with antipsychotics, one we treat with a mood stabilizer. Which is it? Oh gosh, that can be a hard decision. Psychiatrists will often do what's called a response to intervention. They take their best guess. After collecting all the symptoms, they're looking at things, it's still, they say, you know what, I'm going to go with schizophrenia with mood. They treat with an antipsychotic. 4 to 6 weeks, there's no improvement in the symptoms. They say that's a misdiagnosis. It's mood with psychotic features. They take them off the antipsychotic, put them on the mood stabilizer. Woohoo, the symptoms are cleared. So that's the second approach. It's called response to intervention. Typically, with this court involved pathology, we have an extended period of time where they're trying to do therapy and it's not working, and they're trying to say maybe it's just normal range problems with the targeted parent and child that we need to fix. If it's not working, you've already had that trial. Let's give it another try. Let's give it the trial that it might be psychological child abuse, if there's enough symptoms to support that. And so we just do a response to intervention on that. Protective separation, 90 days, that's not a severe separation. When you think about these targeted parents who haven't seen their child in years, a 90-day protective separation to see if that's the pathology of child abuse over here, well worth it. Well worth it. And it's not destructive. We never separate a child from a parent. Never, ever, ever, ever. That's creating attachment pathology in the child. And that's going to harm the child. Separating a child, even from an abusive parent, is going to, well, I'll get to that in a second. But separating a child from a parent is going to cause attachment pathology towards that parent, harming the child and harming that parent. The only reason we separate a child from a parent is a child protection response. That's an abusive parent, and we need to separate the child. But then we want to fix that parent as fast as possible and get the child bonded back into that non-abusive parent as much as that parent can provide and is available to that child, because that's a key issue. Moms are important to children, dads are important to children. And we want the child to feel loved by both parents. That's important for their healthy development. So we don't separate a child unless there's child abuse. So let's do a proper risk assessment, see if it's child abuse. If there is, we will protectively separate the child. Now, for parents who ask me, what can I do? What can I do? How can I get my child? What can I do? Hold on. We cannot ask the child to reveal their authenticity until we can first protect the child from the retaliation that's sure to come from the pathological parent. If I get the child to bond into the targeted parent before I can protect them from the retaliation, I'm just exposing that child to child abuse when they go back with the allied narcissistic borderline dark personality parent. The child is doing what they must do to survive in this situation. Oftentimes, the pathological narcissistic borderline dark personality parent will manipulate the early situation to get full possession of the child. That communicates to the child, you're the powerful one and the other parent isn't. They cannot protect you. I have you. So that child has to collapse into that parent. It's like a hostage situation. The other thing that that parent does is they go vulnerable. They go the victim. Which draws the child's nurture in to support that parent, because that parent's the more fragile one and needs them. The allied parent's doing okay. They'll be okay. I mean, the targeted parent. The targeted parent's okay. They'll be doing okay. It's the allied narcissistic borderline dark personality who's the fragile one. So they will draw the child in this protective role. It's called a role reversal, and it's also using the child as a regulatory object for that parent. Very destructive type of relationship. But it looks bonded. The child will say, "Oh, I love this parent. They're wonderful. They're the best parent ever." No, that's the parent is the one who wants all the protests of love and to be loved, and it's all going that direction into the parent's fragile self structure. They're using the child as a regulatory object, so it's very destructive. So, with this pathology, it is up to the mental health professionals to see it. And the child's going to be saying, "Oh, I hate this parent and I love this parent," and all these sorts of things. He's going to be giving a pattern of symptoms. It's up to us to recognize what that pattern of symptoms mean and are, and whether it's a shared delusion, factitious disorder, and child psychological abuse, so we can then protect the child. So I'm about, I'm about 35 minutes in here on my discussion of child or treatment, and I haven't left diagnosis, because the diagnosis is child abuse, and that is a very specific type of treatment. We do not begin a treatment plan with any dangerous pathology. There's 3 dangerous pathologies: homicide, suicide, and abuse. Child abuse, spousal abuse, and elder abuse. Those are your 3 dangerous pathologies. We're required to do a risk assessment whenever we encounter a dangerous pathology. Suicidality, we need to do a risk assessment. Child abuse, we get most of them over to CPS for that risk assessment. Psychological abuse doesn't go over there. But we still need to do a proper risk assessment for possible psychological child abuse. It's a DSM-5 diagnosis. And so when we have a dangerous pathology, suicide, homicide, or abuse, we first go into what's called a safety plan. So if I have spousal abuse, it becomes a safety plan before the treatment plan. We first make sure everybody's safe. Typically, that's a crisis intervention model. So that's more active, it's more proactive to make sure everybody's safe. I'm not doing psychotherapy with a actively suicidal patient. No, I'm getting them evaluated, possibly into a hospital. I'm getting them protected, activating the resources around them. I may even break confidentiality to a degree to get them protection. So we're into a safety plan. Once everybody's safe, then we go into a treatment plan. So what I've been talking about up till now has been the first thing we need to do is get a proper risk assessment for possible child abuse. In all cases, the moment it pops back into the court, just flip it out to clinical psychology. Let's get a proper risk assessment for possible child abuse that can then inform the court's decisions. If there's child abuse, we then go into a safety plan. We protect the child, and then we go into a treatment plan once everybody's safe. For child psychological abuse, I'd recommend probably about a 90-day protective separation period. That's just a general guideline. Now, I'm open to adjusting that a little shorter based on if the child recovers more quickly and we stabilize the child. So that's the outcome measure we would be looking at, or extending it if there's continues to be psychological child abuse. If there continues to be physical abuse of the child, if the parent continues to use electrical cords to beat the child, we continue to protectively separate as long as that abuse risk is there. And so it can be extended, but generally, if you ask me, I'd say about 90-day protective separation would be a ballpark on that. That could be adjusted. Dorsey Bruder has a high road workshop for family reunification that will recover children from complex trauma and child psychological abuse by a parent within 4 days. 4 days. Amazing. I think professional psychology should be showing much greater interest in her work. I've escorted her to the AFCC to explain it. I've escorted her to the APA to provide them with the data that supports it. Single case ABA design that she recovered the child in 2 days. She's so skilled at what she was able to do. She was able to modify her 4-day workshop to get a recovery in 2 days because it had to happen. So if you can, it's expensive because Dorsey's time is limited, and it's well worth it. She deserves every penny of everything, but it is limited availability because of that. But if you have the opportunity to get a high road workshop in, that would be my first recommendation. If there's a high road workshop, then it could possibly even be less than 90 days because the child starts recovered. If we have to go into my psychotherapy models, we're going to be about 4 to 6 weeks. I'd hope 2 weeks, but 4 to 6 weeks would be reasonable to think about a full recovery of the child. Then we stabilize the child for 6 weeks. That would give us our 12-week period that I'm estimating. It's much better if we get it recovered at 4 days, and then we can go into sort of the stabilization period right there. But putting Dorsey aside and coming back to my world of psychotherapy, if you just protectively separate and then move into psychotherapy, what type of psychotherapy should we be doing? And my recommendation on this, as a clinical psychology, bringing back clinical psychologists to court-involved practice, is we need a court-adapted model from dialectic behavior therapy, court-adapted dialectic behavior therapy, DBT, and informed as the family therapy, that's the family therapy, and then informed by the attachment knowledge, particularly entronic breach and repair sequences, but also just the overall competence in the attachment system and attachment pathology. Children don't reject parents. That's nonsense, absolute nonsense. But these forensic psychologists believe it. Adults reject adults, spouses reject spouses. Children do not reject parents. An adult child can sever from a parent. That's called an emotional cutoff. But a child at this level, no, because the attachment system is motivating bonding for a variety of reasons. It's goal-corrected primary motivational system, and its set point is to form an attachment bond to that parent, never to sever the attachment bond. So an understanding of that, an understanding of how to repair a breached relationship. It's a breach and repair sequence. There's things we do to repair, and understanding that. Now, because no therapy has been here for 40 years, we're going to have to recruit my clinical people into the courts. And DBT is the one you want. And the reason is it's cognitive behavioral model. So it's very structured. There's a lot of empirical research to it. It was developed by Marsha Linehan for the treatment of suicidality in borderline personality patients. And so it's dealing with a high danger, high risk symptom of a personality disorder pathology, which is similar to what we have in the courts. We have narcissistic borderline dark personality, so we have the personality pathology of the adult, and we have a dangerous symptom, child abuse. And so the orientation and structure of DBT is strong enough to deal with the type of pathology we have here. Now, I've also mentioned emotionally focused therapy. That's Sue Johnson. That's a couples therapy, and it's attachment based. She used a lot of the attachment knowledge, family systems knowledge I recognize, and but mostly that's a humanistic existential model. It's using Rogerian client-centered therapy. That is not appropriate for delusional thought disorders, for personality pathology, or child abuse, and especially the child abuse. Sue Johnson, in her trainings, says EFT is not appropriate for dangerous pathologies. That means suicide, homicide, abuse, child abuse, spousal abuse, or elder abuse. EFT is not appropriate for them. This Rogerian type of therapy is too non-directive. It's too soft for that type of pathology. That's why it's critical that diagnosis guides treatment. To simply apply a treatment to a non-diagnosed or a misdiagnosed pathology, you're treating cancer with insulin. The patient will die from the misdiagnosed cancer. So we want the structure of DBT. In particular, DBT, based on cognitive behavioral stuff, has an understanding for behavioral psychology from the 1960s. Okay, we're going back to the 1960s because that's how bad the forensic people are. And what it is that we will be bringing over, an important aspect, will be the applied behavioral analysis. So that's a very structured way of determining what the cue structure is. What is cueing the behavior? And it uses a type of interview technique called a behavior chain interview. So let's say I have an incident between a targeted parent and the mother. What I will do is for an ABA or applied behavioral analysis, you start right before that conflict happened. You say, what were you doing? Okay, before it happened, what were you doing? Okay, so you're in the living room playing video games. Okay, where was your mom? Okay, she's in the kitchen and, cleaning up or making some food or something. And then what happened? Okay, so your mom comes into the room, and then what did she say? So she said, you need to end your video game, we need to go to the store. Okay, then what did you say? You said, I don't want to go to the store, I want to go out to eat at a restaurant. Okay, then what did your mom say? She said, we can't afford that, we need to go get some. So you walk through step by step. What did you say? Then what did they say? What did you say? And what did they say? And you're looking at three features. The antecedent, what came before, that's your cue. So the mom comes in and says, I want you to end your computer game because we're going to the store. That's the cue for the response. The behavior, that's the second part. The antecedent, then the behavior. And that's the response of, I don't want your food cooking, I want to go to a restaurant, which then gets the consequences of the parent saying, no, we're going to the store, which becomes the cue for the next one. And so they're cueing each other back and forth on this, and one consequence becomes the cue for the next behavior, which becomes the consequence, which becomes, and so it's a behavior chain that you construct, looking at what is cueing the behavior. Now, this should be done all the time with the child's complaints, every single child complaint. Not every single one, I'd pick three, maybe two. Two or three of the child's top complaints and about the targeted parent, and let's walk them through. What happened? What did you say? What did they say? What did you say? I like to do it with both people. I like to do it with the parent and the child and say, okay, let's talk about this situation. What happened? What were you guys doing ahead of time? Then what happened next? And what did you say? And what did you say? And a lot of times the child says, I said, I don't want to, eat your food. I want to go out to a restaurant. You go, Mom, is that what he said? And no, he started calling me all sorts of foul names. And I told him to go to his room. Did you start to call her these names? And he said, well, yeah. So, well, you didn't tell me that before. Kind of modified reality there. And so that's the importance of an applied behavioral analysis. You can identify whether that conflict is authentic to the cues or not. The idea here, the term for it, is called stimulus control. That's the term out of behavior therapy. And what this means is that the stimulus controls what we do. Behavior is not controlled by the consequence, behavior is controlled by the cue. Really important. Just drive this into students. Behavior is controlled by the cue, not the consequence, not the reward or punishment. It's what triggers the behavior, the cue for the behavior. And that's the stimulus that has control over the behavior. Let me give you an example. You're driving down the street to an intersection. Now, if you just zoom through, you can have a major accident or get a traffic ticket or something. Bad things can happen. But you don't really think, oh, I'm going to get an accident. What do? You look up at the traffic light, the cue. If it's red, you stop. If it's green, you go. If it's yellow, that's a transitional warning. So you make your driving decision based on the cue of the traffic light, not the consequence of a potential ticket or traffic accident. And so that's the stimulus controls your behavior. Now, in these parent-child conflicts, easy peasy. You get the parent and the child together, and the child says, I don't like what this parent's doing. The cue for the behavior is you walk it through and you get I don't like the child, my mom's cooking. And you say, well, okay, let's change your mom's cookie, or let's go out to dinner, and let's put that in the treatment plan. Let's change the stimulus that your mother is giving you from a red traffic light. You see it as a red traffic light, so let's change it to a green traffic light. We do that. Mom cooperates. She says, oh, I love you so much. You're the best child ever. And the child says, I still don't want to be with you. Wait a minute. We just changed the light from red to green, and you're not going because your behavior is not under the stimulus control of the traffic light. I could change the traffic light to green, red, blue, yellow, magenta, purple. It doesn't really matter what color I change the traffic light to. It's not going to change that child's driving behavior or relationship behavior, because the behavior of the child is not under the stimulus control of the targeted parent. It's under the stimulus control of the allied parent. There you have your cross-generational coalition. So I need to be wrapping up here, and I just barely got into behavioral psychology. So I'll come back to treatment at some point and talk more about this. But there's all sorts of ways to identify authentic from inauthentic conflict, whether it's delusional or not. But one of the advantages of dialectic behavior therapists is all dialectic behavior therapists will be trained and understand behavioral psychology, which is the applied behavioral analysis, the cue structure and stimulus chain. Plus it adds mindfulness, which is important, valuable to the trauma pathology and the child's stress and things. And so that's a wonderful component. In addition, though, DBT was developed for the treatment of borderline personality and suicidality. It's not developed for the parent-child attachment problems that are the product of that personality disordered parent. So it's going to need slight adaptation to the family courts. But in addition, its focus originally is on suicidal behavior with a borderline. We're going to need to repair the parent-child attachment bond. So we're going to need to bring in the attachment literature on that, or attachment research. Sue Johnson is strong in that. And so I would recommend that EFT therapy be readapted. It's adapted out of child attachment therapy into spousal therapy. It needs to be readapted back into the parent-child relationship therapy and employed within the context of the DBT family therapy. So the structure is the DBT therapy, the information's coming out of EFT. The dialectic behavior therapists do an applied behavioral analysis. The the EFT therapist in attachment is called a process analysis of the communication going back and forth. And so it's basically adding a little bit of process analysis of the communication and the attachment communications as part of the cue structure of the applied behavioral analysis. But it's going to take a little bit of adjustment. What you will find, though, is that the DBT therapists and the EFT therapists won't come back and work with you because you're too dangerous. They don't work in the family courts, and it's beyond their boundaries of competence. They're not competent in the treatment of attachment pathology or delusional thought disorders or factitious disorders or the family court pathology, and so they tend to stay away. Rightly so, but we will need to bring them back. Forensic psychology is a failed model of service delivery. We need the clinical psychologists to come back. So we need to make it safe for them. That's my role. Bringing back the clinical psychologist. I noticed there's somebody posted a notification about an EFT seminar or something on court-involved high conflict divorce. I'm likely to take that and potentially get a hold of the instructor because diagnosis guides treatment, and EFT is not appropriate for child abuse or spousal abuse diagnoses, which is what we have in the family courts. EFT is not appropriate for a delusional thought disorder or factitious disorder imposed on another associated with those dark personality pathology. So it's not the appropriate lead therapy for this. It's Rogerian. It will believe the child. It will contribute to the child abuse by not properly diagnosing it. But if within you lead with DBT therapy as the family therapy, then you add the principles of EFT, emotionally focused therapy, to the parent-child attachment bond, not to the spousal bond. That's spousal abuse. We do not put an abused spouse into marital therapy with the abuser. Nope. And so that's again where these diagnoses are so important. I would say we should consider spousal abuse on every case. I think the targeted parent moms will have a more socially acceptable presentation of that diagnosis. The dads may have more difficulty, but it is true for both of them. The underlying feature of this in almost all cases, in many cases, is the spousal abuse of the ex-spouse using the child as a weapon. And so the forensic psychologists and the reunification therapists, there's no such thing, are colluding with the child abuse and colluding with the spousal abuse using the child as a weapon because they are not properly diagnosing it, accurately diagnosing it. They're not conducting a proper risk assessment for possible child abuse, and they're just making decisions on a misdiagnosis. So let me think. Oh, the final piece. I got a couple of seconds here. The final piece. So we have DBT therapy coming back into the courts, adapted to the court situation and the nature of the pathology we find here. We inform it with the attachment information about the breach and repair sequence and about the breach and repair sequence and attachment, the attachment system and attachment pathology, authentic, real knowledge. And EFT would be appropriate for that. And the third therapy that I would add in here that I think is important is solution-focused therapy. So there's four schools of psychotherapy. Psychoanalytic, that's Freud and the couch. Cognitive behavioral, B.F. Skinner and the rewards and punishment. Humanistic existential, that's growth and self-actualization. Family systems therapy, which is what we should be applying in families. But there's a fifth model, or fifth school as well, called postmodern social constructionism, social construction school of psychotherapy. And it's got what I call various boutique therapies: narrative therapy, cultural therapy, feminist therapy, solution-focused therapy. And it's the solution-focused therapy that I think is extremely valuable to add to this particular pathology. And you can layer it into just everything about DBT and EFT. It just blends in really well. And essentially what solution-focused therapy says is we construct the problem, then we construct the solution to the problem based on how we construct the problem. So if I have a psychodynamic problem, and then I construct a psychodynamic solution, and you were poorly potty trained as too. If I have a cognitive behavioral construction of the problem, that's irrational thoughts, then I create a cognitive behavioral solution of changing your rational beliefs. So we construct the problem, and we construct the solution based on how we construct the problem. What solution focus says is, why don't we just skip the first step of constructing the problem and construct the solution? So it stays relentlessly on not saying, off the past. There's nothing I can do about the past. What are we going to do from now forward? How do we solve this situation now? And the advantage of solution-focused therapy is for this particular trauma pathology. Trauma always pulls for an unsolvable past. So it's actually the allied parent's childhood trauma that is serving as the core of this pathology, and we can never fix that. We can never fix that childhood. And there'll be grievances the child has about, oh, there were some bad things that the targeted parent did, 2 years ago, and I'm never going to forgive him for that, the unforgivable grudge. It's always pulling for the past. And so what solution-focused therapy does is it cuts that off and says, okay, there were problems. Yeah, what are we going to do about it? How do we solve this and move it forward? And then you solve that within the DBT model of skill development. How do we develop the skills to solve this issue that we have, or the EFT about how our needs, our attachment needs are being communicated. How do we communicate them better to get a better resolution to the situation? So it's dialectic behavior therapy as your main principal model, family model, informed by the attachment literature, breach and repair sequence. Ed Tronick is so wonderful on this. Sue Johnson, the understanding. She brings a number of things to EFT, including some family systems work, some strategic family systems, some satire as well, and then the cognitive behavioral stuff. It's just too soft. It's basically Rogerian, which is client-centered, which is humanistic existential. That's not the one we use. Humanistic existential model should be outside, at least for a long time. You should be in the family system school, the cognitive behavioral school, the dynamic school. Psychodynamic school, when I say COHUT in self-psychology, that's the psychoanalytic psychodynamic school. They're also the attachment people. Ed Tronick is psychodynamic. John Bowlby, psychodynamic. So the psychodynamic school is the attachment people that need to inform the cognitive behavioral treatments of DBT with add some solution-focused therapy, a little salt and pepper. So with that, I'm going to wrap up today and move on to the rest of my day. And join me next Sunday. Find out what I'm going to talk about. I have no idea. So happy Sunday to you.